Good morning. I'm Naman Garg from MD3, and today we will be discussing a case based on degenerative diseases. So moving on with our case, for the identifying data, our patient's name is Mr. Kailash, who is a 72 years old male and is a married and graduated. His occupation is retired sales manager and his religion is Hindu. His address is he lives in Mumbai, India, and the date of admission was March 08, 2022. The interview date was March 10, 2022, and the informants of the interview were the patient himself and his son. The chief complaint was that the patient reported abnormal movement of upper and lower limbs from 1 year and difficulty in walking from 6 months. For the history of present illness, the patient presented with abnormal rhythmic movement of upper and lower limbs since 1 year, started on the distal part of the both upper limbs simultaneously. It was noticed more during rest that got aggravated during movements. Recently, the lower limbs were also affected and was not more on the both great toes. Patient also gave history of difficulty in walking in the form of difficulty in initiation, and once he starts walking, he stoops forward with small and fast steps. However, he freezes during turning and has tendency to fall forward, which is propulsion, and backward, which is retropulsion. There is also decreased swinging of the hands, and there is no history of fall injury, memory impairment, altered sensorium, behavior changes, visual complaints, swallowing difficulty, weakness of one half of the body. For the past medical history, there is no history of hypertension, diabetes, no history of cancer, no history of asthma, no history of COPD, no history of any injury or any accident, no history of any surgical illness, and no history of any psychiatric problem. For the personal history, the patient is a non-smoker, occasionally alcohol drinker. He eats 3 times a day and is a non-vegetarian. There is no known food allergy and drug allergy. And for his bowel and bladder habits, there is regular bowel and bladder habits noted. For the sleeping pattern, it is normal. He sleeps 6 to 8 hours per day. For the environmental history, he lives in a nuclear family with 4 members, and he lives in an apartment flat which consists of 3 rooms. The kitchen is separated. He uses filter water for drinking, and for the toilet water is supplied by the municipality. For the family history, there is no history of similar illness, hypertension, diabetes, TB, or asthma in the family. For the socio-economic history, the family is a middle class family. For the physical examination, upon the general inspection, for the gait, there was shuffling gait with tendency to fall forward and backward. The body build is thin. The patient is conscious with GCS score of 15 of 15, and the memory function is normal, and the facial expressions is masked face. For the vital signs, the temperature of the patient is 36.7 degrees Celsius. The pulse is 78 beats per minute, regular, normal volume and character. For the respiration is 20 beats per minute, regular. And for the blood pressure is 120 for the systole and 74 for the diastole. Mercury in both arms. The height of the patient is 5 feet 6 inches, and the weight of the patient is 63 kg. For the general examination, there is absent pallor, icterus, lymph nodes are not palpable, the clubbing and cyanosis are not present, there is no edema, dehydration noted, and the skin is normal. For the examination of the head, face, and neck, upon the inspection of the head, the hair color and texture are normal. There is clean hairs, no signs of any injury. Inspection of the eyes, there is no discharge and redness of the eyelid, but there is swelling of the eyelid, and there is no other eye problem noted. For the inspection of the ears, there is no discharge and pain, but hearing problem is present. For the nose, there is no discharge, bleeding and swelling problem. And for the mouth, poor oral hygiene, missing teeth and dental caries, no cyanosis present. For the neck, there is no enlarged lymph nodes and no thyroid glands. Normal neck mobility is present. For the CNS examination, the level of conscious for the GCS scale, it is 15 on 15. For the sleep, it is normal, and the higher mental function is normal. For the cranial nerve assessment, the olfactory nerve, for the olfactory nerve, there is no any damage noted in the frontal head, basilar, and facial injuries. The patient is able to correctly identify smells, and there is no discharge, bleeding, and smelling problem. For the optic nerve, there is normal visual acuity and normal visual fields. The area and extent of the visual field is also normal. For the oculomotor, trochlear, and abducent nerve, there is symmetrical, no discharge, no swelling eyelids, no ptosis, and there is normal pupil size and shape, and the pupils are reactive to light and accommodation. For the trigeminal nerve, uh, there is normal ophthalmic, maxillary, and mandibular, and the muscles of mastifications are normal. There is normal temporal and masseter muscles, open mouth symmetry, and the corneal reflex are present. For the facial nerve, for the sensory part, normal taste to anterior two-thirds of the tongue. For the motor, abnormal facial expressions and secretion of saliva, wrinkled forehead, raised and lower eyebrows, smile and show teeth, puffed cheeks, close eyes, and for observe for symmetry. No facial nerve paralysis is noted. For the acoustic nerve, for the vestibulocochlear nerve, the hearing and balance. For the Weber and Rennie test, they both are normal. For the Weber test, patient can hear equally in both ears, and for the Rennie, hear air conduction as long as bone. So Rennie is positive. For the glossopharyngeal and vagus nerve, a taste posterior in one-third of the tongue is normal. Swallowing, gag reflex is normal. Movement of the pharynx is normal. For the accessory nerve, trapezius muscle strength is noted. Sternocleidomastoid muscle is normal. And for the hypoglossal nerve, the tongue movements strength is normal, and the speech sound is normal. For the motor system, then upon the inspection, there's mask-like face present, resting tremor present, no neurocutaneous marker, no facial spasm, no dilated veins or scars. For the palpitation, there is glabular tap present. For the tone, rigidity is noted on the bilateral upper and lower limbs, and there is a cogwheel rigidity present. For the power, there is 4/5 in both uppers and lower arms. For the sensory function, for the deep sensation, there is vibration present. For the superficial sensation, there is pain and touch present. For the cortical sensation, the graphthesia is normal and the stereogenesis is normal. For the patient has a normal 1-point localization, and the patient has normal 2-point discrimination. The sensory attainment is normal. For the cerebral signs, there is no stagmus, adidocokinesis. The finger nose test is normal. The heel shine test is normal. The Romberg test is negative, and the ataxia, there is no ataxia noted. Moving on to the approach. So for the early patient, Parkinson's disease patient, we look for the functional impairment. If the functional impairment is not present, then we move for the non-pharmacological management like group support, education, exercise, and nutrition. But if the functional impairment is noted, then we move for the pharmacological management, which is noted in our case. So for the severe tremor, if the patient is suffering from the severe tremor, we give a specialist referral, or we give anticholinergics or levodopa or dopamine agonist or amantadine. If there is inadequate response or no response to the above medications, then we consider deep brain stimulation. Whereas if the severe tremor is not noted, then we give levodopa or dopamine agonist or amantadine. For the plan of management, our patient was prescribed with tab Syndopa, which was given to him 5 times a day. The first tablet was prescribed at 6 a.m. Then the second was given at 10 a.m. The third tablet was given at 2 p.m. The fourth was given at 6 p.m. and the fifth tablet was given at 10 a.m. So with an interval of 4 hours, the patient was asked to take Syndopa. The other medications were given were pramixi-pexole 0.5 mg thrice a day, tablet pentaprazole 40 mg 2 times a day, and tablet domperidone 10 mg thrice a day, and tablet trihexyphenilyl it was given 2 mg twice a day, and a syrup was prescribed which was known syrup lactulose was given in was prescribed in night for 2 weeks, and the follow-up was asked for after 1 month. So that's all for our case. Thank you for listening.